We have all of your lines on mute currently right now, but we do encourage any questions that you have to be placed over on the right-hand side of your screen in the Q&A section. We'll take a few minutes at the very end of the presentation to review some of these incoming questions, but note if we really don't have time to get to your question during the presentation or afterwards, that we'll reach out to you directly with our responses. All the Q&A covered today will be posted along with the presentation slides on our Galen Wiki. But if you would like a copy of the presentation with the recording, please contact us at Galen at sales@galenhealthcare.com. So with that, I'll turn it over to Matt and we can get started.
Good afternoon, everybody. I'm Matt Hoover. I'll be doing part of this presentation today. I'm a consultant on the technical services of Galen Healthcare. I have a BBA and Bachelor of Management Information Systems. I've been working in healthcare IT for a little over 5 years in some clinics as well as a consultant, and I have over 10 years of analytics and business intelligence experience.
And I'm Christy Mitchell. I'm a senior consultant on the professional services side here at Galen. My concentration is mainly with meaningful use. I'm certified with that currently and been working in healthcare IT for at least a minimum of 8 years, both in practice side as well as outside and consulting efforts here at Galen, with most of my focus lately being on these internal quality efforts and a lot of these quality incentive programs.
Thanks, Christy. I'd like to start with a brief intro of what quality incentive programs are and what they entail. Quality incentive programs have been and currently are being developed to move towards a value-based payment system. The programs often focus on improving patient care while at the same time reducing costs. Many of the quality measures focus on monitoring and managing those patients with chronic illness and measure application of preventative medicine, including immunizations, routine mammograms, and colorectal screenings. A few examples of these QI programs include the Medicare Shared Savings Program, the Medicare Accountable Care Organization, otherwise known as the Pioneer Program, and the Physician Quality Reporting System, also managed by the Centers for Medicare and Medicaid Services. In addition, individual health plans have their own HEDIS reporting specifications and programs, and some practices may even have internal programs to improve healthcare. The individual measures for these programs are developed using evidence-based medicine, meaning many of these programs share the same or similar logic for the individual measures. If evaluating a particular quality improvement program and the incentives available, additional opportunities may be available in similar programs. That's not all. Many of these organizations are now developing their own internal quality metrics to improve care and reduce costs. To evaluate the basis of quality improvement reporting, let's dive into the Institute for Healthcare Improvement's triple aim definition. The Institute for Healthcare Improvement defines triple aim as improving the patient care experience of care, improving the health of populations, and reducing the per capita costs. I think we can all agree that's where healthcare is headed. To put things in perspective, this image illustrates how costs increase dramatically when chronic illness isn't managed. A primary goal of any quality incentive program is keeping patients from moving up from one category to another. It's much more difficult to move down than to maintain healthy patients and manage those with chronic illnesses. Of course, the patient needs to be engaged and participate in managing their own health as well. Education and telehealth, portals, and integrated phone apps like Galen's own Dragonfly are helping to make patients more aware and active in the maintenance and management of their own health. As you can see looking at this image, the unmanaged population really has the highest cost level on the other side. You know, these are the type of patients that are maybe have end-stage renal disease or unmanaged heart disease. It's much easier to keep them managed and keep that cost a little lower and then to let them slip up into a category. It's very difficult to move them back down. If you think of the IHI triple aim not as individual steps, but categories that work towards an ultimate goal, it's easy to see how effort spent working on some of the measures can have a great impact across the continuum of care. The first category category we will take a look at is improving the patient care experience. This category focuses on care delivery as a service. Attention is given to all patients' overall satisfaction with the service that they have been provided and is often reported via questionnaires and feedback solicited directly from the patients. Some of these items, for example, elimination of duplicate testing and streamlining workflows, not only improve patient satisfaction, they also contribute to a reduction in costs. The next category, population health, focuses on maintaining the health of patients grouped into populations based on age, gender, or chronic illness. Measures are developed using evidence-based medicine to establish common protocols aimed at preventative medicine, like immunizations and regular mammogram screenings, and management of chronic illnesses like diabetes and heart disease. Many measures in these categories seem repetitive, but they measure care in different ways. For example, PQRS measure 236, controlling high blood pressure, focuses simply on monitoring the patient's blood pressure and ensuring it's within the acceptable range, currently less than 140/90. Measure 317, on the other hand, screening for high blood pressure and follow-up documented, focuses not only on recording blood pressure, but also the follow-up process if a patient presents with hypertensive or prehypertensive blood pressure. For example, if a patient is seen and is hypertensive, this measure requires that the patient be educated and a documented lifestyle modification is recommended to the patient. Examples include DASH diets, weight reduction, increase in physical activity, etc. Additionally, this measure requires that the patient be rescreened within 4 weeks. If still hypertensive, there is a secondary list of lifestyle modifications, including drug therapy, that must be followed in order to meet the measure criteria. I should note that these measures are not intended to replace the judgment of a physician, and many of these measures include exceptions that, when documented in the patient's chart, allow for substitution or alternate treatment plans. In the arena of quality improvement reporting, it's critical that thorough and accurate documentation be saved to the patient's chart. If at all possible, saving it discreetly will ease the reporting burdens at a later date and make auditing much easier. The final category focuses on reducing cost. It's important to note that reducing cost in no way implies a substandard level of care. In fact, it's quite opposite. By providing preventative measures like immunizations, regular mammogram, and colorectal screenings, this category focuses on keeping patients well and reducing inpatient admissions and ER visits. At this time, I'd like to send it over to Fallon for a poll.
Thanks, Matt. For the first poll, we're interested in what some of your current barriers to reporting are. So I'm going to open this up. I'll leave it open for about a minute. So whether your barriers are, your limited access to the data, if you've got issues with your workflows that you're working through, or, some of your analysts, making sure that they have the right skill set. We're just kind of interested in who we've got in the audience and what your challenges are. So it looks like right now the clear leader is limited access to the data, which we've definitely seen before for some of our clients. But there's also some people with workflow issues. Looks like limited skill set isn't an issue for anyone in this call. So I'll leave this open for about 30 more seconds, if you wouldn't mind just continuing to answer. And I'll pass it back to you for now, Matt.
Thanks, Fallon. We've worked with several clients who are considering or already involved in quality improvement programs. These interactions have uncovered several common issues in the quality improvement realm. For many health systems, as it is actually noted in the poll, these measures present unique challenges, not because the treatment plans are difficult, but because the patient's data is spread out over several disparate systems. Many health systems have separate systems for ambulatory, inpatient, radiology, and more. These systems might be connected via interfaces, but to truly see a picture of the patient's health and be able to report on quality measures, it's imperative that the data be available for reporting from a single, easy-to-use data warehouse. Because it's hard to paint a picture of the entire patient's continuum of care, many providers and health systems are missing out on incentive payment opportunities. These opportunities could increase per patient per month payments in the case of managed care insurance lines, or avoiding possible reductions in payment for poorly performing groups. Additionally, many systems lack the ability to track these measures over time, which allows insights to the effectiveness of workflows and treatment plans developed for patient populations. When considering involvement in any quality incentive program, it's imperative to develop an approach that not only provides information relative to the performance based on these measures, but allows a holistic view of the patient's health and well-being. Galen has been working to develop an approach that is more than just reporting, but includes provisions to use the actionable data delivered by reports to create a quality improvement lifecycle. A few of the major components include a data warehouse designed to contain data from all of the disparate systems, including practice management data and clinical data. On top of the data warehouse, a system that defines measures and provides detailed and aggregate reporting allows for trending of performance over time and is flexible enough to allow for standard measures as well as internally defined measures. One key element we focus on, outside of the technical and reporting elements, is consulting services. Galen consultants work with staff to identify workflow improvements and gaps in the data needed to satisfy reporting measures. Christy will be going into this in a little more detail later in the presentation. When considering any approach to quality incentive reporting, it's important that someone is monitoring improvement and looking for outliers needing education or assistance to improve scores and patient care. Regardless of what solution is chosen to assist in quality incentive reporting, it should be focused on closing gaps for reporting and documentation of patient care. A good solution will incorporate all the data necessary to create a complete picture of the patient's entire continuum of care and provide a single source of reporting to the program entities, whether they be government, private payers, or internal quality improvement teams. A great solution will provide trending capabilities to monitor improvements over time and highlight troubled areas. These solutions can help maximize returns by replacing manual reporting with bulk data collection. Galen's solution has been developed to be source agnostic, allowing data to be collected from multiple EHRs, including Epic, Cerner, TouchWorks, Allscripts Pro, and a myriad of other systems, both clinical and administrative. This solution combines the data into a single reporting instance using common technologies like Microsoft SQL Server. We've heard stories from clients that involve manual data entry when it comes to reporting time. Essentially, the staff spent days manually entering this data and submitting it to the reporting authority. This resulted in increased costs and lost opportunity for the staff that could have been assisting and educating providers with quality incentive programs instead of spending time doing manual data entry. The Galen solution not only focuses on reporting simply for quality measures, but also helps measure the effectiveness of new workflows and how they correlate to improving patient care. This diagram illustrates the Galen approach. We begin with feeding data from multiple systems into a custom-built data warehouse. Measure logic is applied to the data, producing actionable data in the form of reports aimed at improving patient care at the individual, provider, and group levels. These reports are analyzed for potential gaps in care or data collection issues, resulting in modification of workflows and action plans to help improve scores. This feedback loop includes communication to providers and staff about the opportunities that exist and options for implementation. If modifications are made to the workflow, the effects can be monitored using trends in measure scores and internally developed measures. Communication is imperative to the success of any quality incentive reporting program. Including subject matter experts, physician champions, and quality improvement teams isn't enough. There has to be a defined feedback loop to ensure that any efforts are executed and monitored. At this time, we'll take another quick poll, and Christy will go into more detail on the consulting aspect of the Galen AAAM approach.
Thanks, Matt. For this next poll, we're interested if you're currently using a data warehouse or other type of reporting solution. So again, I'll leave this open for about a minute. We'll let people, give people a chance to answer. It looks like we've got a pretty good mix. We've got some people that are evaluating their options, some people that don't currently have one, and quite a few people that are currently using one. So I'll leave this open for another 30 seconds or so to give people some time to answer, but I'll pass it back to, I believe, Christy.
Yep, thank you, Fallon. What I wanted to do now is turn things over to that analyst perspective. I think it would be really silly not to discuss all the great things that we can now do with this data. In my opinion, this is the fun stuff. I'm going to cover the topics of what we can do for you once it's actually physically in your hands. As you can see, there's two main steps here. First, doing a gap analysis of the reporting calculation, and second, to optimize your organization's capability to run your daily workflow top to bottom seamlessly. The gap analysis will focus on doing a comparison of the actual performance data against your desired potential, or basically your chosen specific measure criteria. What that means is that our work here at Galen is to determine all the missing pieces to meet the measures of your selective reporting incentive programs. In the analysis, the final product in this gap analysis could be a report, and it's going to outline specifically what you need to do in order to meet that measure specifically. So we'd work together with your system analysts, determine the areas of adjustment that will need to be implemented, and then, of course, the methodology in which we recommend to roll this all out. Moving into the optimization period, we then focus on what we want to do with that report generated from the gap analysis, where workflows may need to be adjusted, system configuration updated, and then those general system updates such as adding in new products, doing a module implementation like charge, and of course any planning for future upgrades and hot fixes. As we kind of go through all these different topics of optimization, we're going to work to create specific training that's geared specifically just to increase productivity. Determining training methodology, whether it's going to be written materials or classroom training. We obviously can assist in rolling all these new features out, and in the end, it just results in all that good stuff that we want, everything that we've been discussing since the start. We want better care, shared patient-provider responsibility, patient savings, and increased revenue, and to gather all those incentive dollars for your organization. So to begin, let's center on this gap analysis. It's really only here that we determine all those next steps and begin to create this roadmap of what's needed, or rather what you're succeeding or failing at. In a reporting type platform, this would be inclusive of data validation and the identification why certain patients did or didn't qualify for your measures. So when we do these deep dives into the validation of the data, we do so in a way that captures multiple pieces of the measure criteria. So in a sense of all the word, we validate. We're looking at upwards of a 10-point checkup on each piece of data that the incentive measure is looking for. It could be of an importance when a specific order is placed, when it's resulted, and who the ordering provider was. Looking at one order of a patient that passes and then to another that doesn't, we need to identify what differences were and highlight them for updating. Oftentimes, it could be just as simple as a code update in the dictionary or a small workflow adjustment in the ordering process. So this is a quick example of what a gap analysis can provide, and is a very common measure selected by multiple specialties, almost every organization that I've worked with. This is the easy one. This is measure NQF 18, ACO 28, PQRS, controlling high blood pressure. As you can see, it pretty much covers all of these incentive programs that I bet that you guys are all attesting for. So it's really easy. You would think that you're all meeting it, but really are you? When we look at the simplicity of entering in a diagnosis of hypertension, there's really only a few supported entries of hypertension that the measure supports. Have you provided your doctors with a favorites list to identify those? Maybe an order group that's specific for some of these measures? Just a few ideas there. When you're doing this gap analysis on this particular measure, I'm sure it won't be as simple as the incorrect diagnosis. For this measure, it's going to be that blood pressure capture. So have you taken the time to review all the measures for proper coding? Are your users educated on the importance of capturing the blood pressure at every visit? So this means not only educating your staff on how to use the application to capture it, where the vitals panels is, but also how to interact with patients and educate them on the importance of capturing vitals. So it's not always going to be the blood pressure that the patients refuse, but as soon as we provide education about their care, put a little bit more responsibility into the patient's hands, and really allow them to make informed decisions, we start to see them contributing to the care just as much as the doctors that see them every time that they come into the office. So there's always going to be a few different reasons for not capturing vitals. Maybe forgetting to capture vitals because the schedule is running behind, because it might not be a regular office visit. You're now going to face some repercussions in those actions. So right now it's even easier to simply indicate a reason why it wasn't done, and then making sure that the documentation of that event is coded and then searchable for reporting purposes. So what we're looking at here is a really, really, really small snippet of the data. This is what a reporting might look like if you were to get this from us. And although we really do provide a lot more information than what could be squeezed into the slide, I just want to point out those last few columns of the report. Most importantly, we identify who's passing the measure per patient, what their last blood pressure readings were. So this particular measure is looking at a range of blood pressure that indicates the control of the patient's hypertension. We also provide that last reading to you. So potentially this is a level of education to even your intake staff to assess that last blood pressure and assist the provider in the control of this active problem. That's the whole reason why the patient is there. So looking at the report, you're going to see a few of these last columns that I've kept open for us. Column L, this is that last blood pressure reading. This is what that measure is looking for. We're controlling it, so we want to assess what happened last time they were in. Column N, that was the date that it was done, so you can kind of gauge on how often this is happening for our patients. Column N is this measure value, which is your pass or your fail. We've assessed a 1 for pass and a 0 for fail. In summary, at the end of this report, you're going to see how we measure all of this into a percentage for you. In column O, most importantly, the measure value description. This is going to show you where your patients are passing, whether a blood pressure wasn't even captured, or if it was outside of the required range. So this gap analysis ultimately determines why patients are passing and if interventions need to take place, if coding and vitals need restructuring, or there's a bigger trend that needs a little bit more attention. So of course, this is probably the easiest measure of the bunch, and the analysis here would be really simple and straightforward. But once you bring in multiple layers of requirements, you start to open the doors to identify a ton of places where updates will need to be made on all sides of the fence. So now I want to take a little focus on those next steps, taking that gap analysis and turning it into a feasible solutions for your organization. The optimization stage will be tailored exactly to fit your organization needs, and it's going to be made up primarily of the items that you see here, all with that final goal to help you first find focus in the measures of the incentive program. Supporting these steps will need project leadership, rollout strategies, and resource allocation. We can also assist in the build methodologies, the planning, and really the structure of the project as a whole. So I guess starting with workflows. We all know that every organization, every office, and every provider tends to lean to workflows that just optimize patient visit times. And sometimes that comes at the risk of not capturing all the necessary data that you need. So in doing a workflow analysis and updating these, we aim to meet the measures, but want to be sure that while we're personalizing everything, we keep in mind the main objective to keep things simple. Capture what you need, decrease user clicks, and do away with all these frustrations of the system that just constantly keeps on changing. So, of course, once we dive in and take a look around, there's going to be areas of the EHR that will need additional thought and planning to roll out. There are products out there that could certainly make life a lot easier. For example, eCalcs. eCalcs have been a great solution for multiple measures within the incentive program. We have eCalcs for fall risk, depression screening, and a lot of problem-specific measurements. And another one, take Pinpoint. Pinpoint is a perfect example of a product that's developed only for the sole purpose of meeting the core coordination standard that all of these measures are trying to develop. So optimization really is a big project, and it's going to be built with only you in mind. We want you to meet these measures successfully and to move forward with the proper tools that you're going to need to maintain your environment. Circling back, considering the measure that we looked at earlier, we've learned in that in some areas your data is showing that you're not meeting the measure. We'll be focusing more on what we can do to show you what you need to meet this, and then contracting in the rollout. Since we selected a measure that's not built with a lot of coding requirements, our focus for this one would surround workflow updates, clinical documentation requirements, and then suggested rollout of any new products, which would be, of course, inclusive of the whole gamut on that, the project management, training, and then the rollout plan that might be required. But what I can say is that post that engagement, you're going to be meeting these measures a lot better if you follow these recommendations that we set aside for you. And on that, I think I'm going to turn it right back over to Matt.
Thanks, Christy. I believe we have one more poll.
Yes, we do. So we're interested in this one, a little bit more of who our audience is, but if you're currently enrolled in any quality incentive programs, and if you're involved in multiple, you can check all that apply. But we know some of you are, and so we're just kind of interested in what it is that you're involved in right now. So it looks like a lot of people are answering. The leaders right now look to be PQRS. We've got a few PCMHs, HEDIS G-Pro, pretty much across the board. We've got a lot with PQRS in the lead. So I'm going to leave this open. Everyone seems to be entering their responses, so I'll leave it open for about 30 more seconds and pass it back to you, Matt.
Thanks, Alan. So reporting quality incentive measures isn't the only benefit. It's also possible to build dashboards and other reporting solutions to provide a single reference point for data that might not be available within a clinical system or is spread out in several areas of the record. These reports can be used to provide a single point of reference when seeing a patient or be used by management for internal compliance monitoring. For those of you using Allscripts TouchWorks, this solution can partner with Galen's own no-form reporting, otherwise known as NoXML, to parse V11 notes into discrete data elements available for reporting. Galen's no-form reporting is a unique solution that unlocks the power of Allscripts V11 note. For many practices, certain key data elements, especially like depression screening, are only available in the notes. This presents a problem when trying to report, as there is no built-in method for obtaining discrete data from most of these notes. No-form reporting solves this dilemma by transforming the V11 notes stored as XML into discrete data elements stored locally in a SQL database. Quality reporting isn't the only use for no-form reporting. Many clients also use this process for charge and workflow automation. Like I said, a great example of NodeXML use is the depression screening. It used to be required that you only had to administer a depression screen. The result didn't necessarily matter. You just had to do it once a year or whatever the interval might have been. Now you have to have the score and follow up on it if that patient presents as depressed, either with further follow-ups, some counseling, medication, etc. So if you're taking your depression screening, say in your visit note, which is probably the easiest workflow, it might be tough to get that data out without this note parsing, and that's where this tool would be used. So if you're considering participation in or already enrolled in a quality incentive reporting program, these are a few tips that will help ease the burden of reporting, regardless of your solution chosen. First, start by ensuring your EHR is configured to use standard codes. A few examples include LOINC, SNOMED, and RX norm. Many programs require that reporting be done using these types of codes, and by ensuring they are already configured in your EHR, it will save a lot of time spent mapping codes later. Ensure that your workflows are documented and communicated throughout the organization. This will help in reducing the amount of places similar data is documented in the chart and ensures the quality and quantity of data is available for reporting. It also eases in audits later on. Finally, ensure that there is someone, or preferably a team of people, available to monitor scores, coach, and assist providers and staff. This person or team should also be responsible for soliciting feedback from providers, staff, and patients to continuously improve the quality of care delivered. Many of these programs provide financial incentives for providing managed care services to chronically ill patients. Payers define the clinical quality measures that will be used and will pay incentives if the entire population meets the established goals measured. Before entering a program, an analysis could be done on the patient population to estimate any increase in revenue or savings due to an avoidance of penalties. For the sake of this simple formula, it will be called R. Using the standard ROI formula, any potential quality incentive reporting solution can be compared based on ROI. It's important to note, ROI calculations don't take into consideration non-monetary gains and those that are difficult to measure, such as improved patient quality of life, streamlined workflows, and time saved manually managing a patient population. On this slide, we've got a few helpful links. The top slides are some of the services and products that we offer here at Galen, and the bottom couple have some CMS information, and CMS has a wealth of information. You could spend an entire day, and I have, and I'm sure Christy has spent several days or weeks trolling through their websites looking for information and documentation. It's all very cleanly laid out. They have spreadsheets with the codes, the standard codes that you need, very detailed explanations of the measures and how they apply, and other resources to help you along the way. I think at this time we're going to take some questions if there are any.
Yep, thanks, Matt. I'm just going to grab 2 or 3 that I'm just seeing here now. Just a reminder, too, if you do have any additional questions, we can easily just respond to them right after the presentation and follow up with you. We'll get started. Here's one for you. Can we use this solution to submit to CMS? Matt, do you want to go about on that? So, okay. Yep, no.
I was muted. CMS uses GPRO, registries, and maybe a couple other methods. Primarily, though, they'll use GPRO or a registry, either based on claims or a bulk data dump. These reports that we design aren't really meant for that because they're more human readable, but we can extract the data and feed it to CMS in a bulk format, which obviously saves a lot of time when we compared to manual data entry. I have heard of people spending 2 weeks to a month sitting down with paper charts and manually typing this data into CMS's website, and that I can't even imagine the effort involved and the cost behind that. So yes, the simple answer is we can submit data with this to CMS.
Excellent. Okay, and does the reporting solution combine data from inpatient and ambulatory systems?
Absolutely. Yeah, we can bring in inpatient, ambulatory, practice management systems, even claims files if they're clean enough. I have seen some instances where certain payers' claim files are a little tricky to work with, but it is possible to bring in claims data as well. If it's clean and quantifiable data, it can be brought in and it can be used to measure goals.
Awesome. Okay, I'm just going to grab one more here. Can we use this solution to create dashboards for providers?
Absolutely. The best benefit, I mean not the best, but a great benefit of having a dashboard for a provider is that one instance, the one spot they can look at, and if it's embedded within the EHR, even better. So they can see before they go in to meet with the patient what their chronic illnesses are, where they're at in their treatment plans, have they got their follow-ups, what's their medication look like, and obviously a lot of this information is available right in the EHR, but you have to click around to get it. This puts it in one spot. Additionally, there might be some information like ER visits that you're receiving either through an interface or through some claim files, and that'll put it right there on the patient's dashboard sheet to allow the provider to ask them, why did you go to the ED? Are you feeling okay? I want to double check the meds because that's obviously one of the new measures coming out, medication compliance. So there's a lot that can be done with that to improve care and reduce costs.
Great. Thanks, Matt.
Thank you.
So that, yep. Okay, so I think this will wrap up the presentation for today. I want to thank you guys all for attending. I know this was just a quick intro to our reporting solution. If you have any questions, please feel free to reach out to any one of us on the webcast today or to our sales team, and we can direct you to some materials that will help you make a good decision for your future reporting needs. Thank you all.
Thanks, everyone.